Hey everybody, really excited to be here. Thank you to the organizers for allowing me to talk. And we'll talk about metastatic non-small cell lung cancer, just a few updates because obviously it's way too big of a topic to cover right now, but we'll do what we can. Some disclosures there. We'll do a scope of the problem, and then we'll talk about the importance of screening. Dr. Ritchie, I caught her talk on screening, which was really great. And the only reason I'm highlighting it again because it kind of ties into what I'm going to talk about. Then IO monotherapy, combination therapies with IO, and then chemo-IO combination therapies. So I have some questions here, but we can just wait on the panel for those. And we look at the incidence of lung cancer, and we know that it's the second most commonly diagnosed tumor in both men and women after prostate and breast cancer. For men, 26% with prostate cancer, but 12% with lung cancer, and 30% with breast cancer in women, and 13% in lung cancer. But we also know that lung cancer kills more patients than the next three tumors combined. So arguably, this is the most important talk that we're going to have today. Okay, so don't even try to fight me on that. It is the most important talk. And one of the reasons that it's most important is because of where we are with lung cancer and survival. We've made some really great impact in the other tumors, and it's really great to hear the data. And what's happened in lung cancer over the last 6 to 7 years has been amazing. I was talking to somebody the other night, and I told them I actually came into lung cancer in a time where immune checkpoint inhibitors were already approved. So I have never treated lung cancer without an immune checkpoint inhibitor. To some of you, that's probably funny, and somebody looked at me and told me I was the youngest person at the table, and I said, that's okay. Yeah, I'm all right with that. But so the immune checkpoint inhibitors have made a really big difference in cancer care, and Dr. Cosman just gave us a really good talk on how we're using those in the earlier stages of disease at this point. But previously, they were most effective and useful in stage 4 disease, and we want to stop diagnosing at stage 4 is the point of my screening inclusion here. So we have the overall survival for prostate cancer and breast cancer, the 5-year survival, compared to lung cancer, and look at how dismal that is, okay? We know that in breast and prostate cancer, screening is widely accepted, as well as colon cancer, which is not a part of this graph. And until COVID, we were having really good numbers for screening, you know, despite the disparities in screening and everything that Dr. Ritchie alluded to. We look at that and how there's a difference between these tumor types and how well, you know, screening has been uptaken. When we look at lung cancer, there's stigma associated with smoking. So a lot of patients feel like I'm going to eventually get lung cancer anyway. These aren't things you don't know, but things that we need to point out so that when we talk to our colleagues in primary care and other areas of medicine, we can point them out to them and the reason that they should be encouraging their patients to get screened. And then there's lack of screening access, whether it's because of lack of insurance. We have patients that are in marginalized areas where they can't easily get to a screening center or screening is not really available to them. And then the screening guidelines may be too narrow, so we end up excluding actually a good number of patients. We look at the 5-year overall survival by stage for non-small cell lung cancer, which highlights the reason that we should be doing this screening and finding these cancers at stage 1A instead of stage 4. And when we look at NLST and the Nelson trials, which kind of showed the survival advantage of screening patients, we saw more diagnosis of lung cancer with the low-dose CT and then fewer deaths from the lung cancer with the low-dose CT. And the reason is because, and I don't know how well that projects there, in the red box you can see that over 50% of the patients diagnosed with lung cancer in the screening trials were diagnosed at stage 1A, where it's largely resectable and curable. So that is a reason that we need to push for screening. Otherwise, we end up continuing to need these therapies that have been developed in non-small cell lung cancer, which are great. You know, pembrolizumab, cemiplimab, atezolizumab, durvalumab, and all of the drugs that we're using in advanced disease and starting to use in earlier disease. These are just some of the landmark trials that brought those to us in clinical practice now. And around 2015 or so, when we start to see the inclusion of these in initially second-line setting, then first-line setting, and in combination with other immune checkpoint inhibitors and also with chemotherapy. So just to look at IO monotherapy, we start with pembrolizumab, initially looked at in KEYNOTE-001, then KEYNOTE-024 for the non-small cell lung cancer patients with PD-L1 greater than 50%. Good performance status, no actionable alterations in EGFR or ALK. They were randomized 1-to-1 to Pembro or platinum doublet chemotherapy, and crossover was allowed for those patients who progressed on their chemotherapy. Primary endpoint being PFS, followed by overall survival and response rate and safety for secondary endpoints. This is the progression-free survival from the Pembro versus the chemotherapy. There was a 50% reduction in chance of progression for patients treated with pembrolizumab over chemotherapy. And we look at the subgroups there in the analysis. Most of the patients seem to benefit. The patient line that's coming really close to the midline, those are the never smokers. And we know from further data that never smokers don't typically do as well with immune checkpoint inhibitors for non-small cell lung cancer, but I caution because there were only like 24 patients in this trial that were not smokers. So really small numbers there. When we look at the overall survival, we saw a 40% decrease in the risk of death from non-small cell lung cancer. Pembro versus chemotherapy, again, is PD-L1 greater than or equal to 50%. And then Keynote 042 looked at pembrolizumab for patients with PD-L1 greater than or equal to 1%. Again, no EGFR ALK alterations, good performance status, randomized 1-to-1 to Pembro versus platinum doublet chemotherapy that was histologically specific, so pemetrexed for our non-squamous and paclitaxel for squamous. They were stratified by their performance status, their histology, squamous versus non-squamous, and then PD-L1 expression greater than 50% or 1 to 49%. Overall survival was a primary endpoint. This table, again, I know it's kind of small, it doesn't break down, but I'll show you over in the left column on the screen, what we see is that about 299 of those patients actually had PD-L1 greater than 50%. And there was a breakdown all the way down to 1%, and that was very important in the analysis where we looked at the PD-L1 expression level based on the percentage. We looked at the overall survival based on the PD-L1 expression level. In the top left, you see all patients, but in the top right, you see PD-L1 greater than 50%, where we saw the most benefit. And this actually is approved for PD-L1 greater than 1%, but in clinical practice, most of us are gonna add chemotherapy for those patients who are 1 to 49% or either PD-L1 0. Atezolizumab is another monotherapy approved in non-small cell lung cancer. Initially, it was looked at in second line based on the phase 2 popular trial of phase 3 OAK trial. It showed improved overall survival and progression-free survival compared to docetaxel. And it was approved in the first line as a monotherapy based on the Empower 110 trial. Empower 110 showed atezolizumab versus chemotherapy, again, histologically specific chemotherapy for patients with advanced non-squamous or squamous non-small cell lung cancer. They were stratified based on sex, performance status, PD-L1 expression, and histology. Atezolizumab 1,200 milligrams every 3 weeks versus the chemotherapy followed by continued therapy until progression of disease or loss of clinical benefit. For the patients who were treated with non-squamous disease in the chemotherapy arm, there was a pemetrexed maintenance, and then there was best supportive care for our squamous cell patients, whom we need to do better for, by the way, because they always fare the worst. This looks at all the patients, and so we did see a benefit with the atezolizumab monotherapy, but this was for slightly lower PD-L1 expression level, whether on the tumor cell or the involved immune cells. For the patients who had high PD-L1 expression, so for this subgroup, they had PD-L1 in tumor cells greater than 50% or immune cells greater than 10%. Those patients had the best response rate, and their overall survival was a 41% decrease in death from the non-small cell lung cancer. So overall survival at 12 months, 64.9%. Versus 50.6% for the chemotherapy-treated arm. So for this, atezolizumab, again, in PD-L1 high patients or greater than 50% is approved as a monotherapy. Cemiplimab is the most recently approved immune checkpoint inhibitor as a monotherapy for these patients. Again, PD-L1 high or greater than 50%. Similar to the other study designs, the patients were treated with cemiplimab 300 milligrams every 3 weeks versus platinum doublet chemotherapy, histologically specific, very similar to the previous trial. And what was nice in the analysis in this trial is that we look at the PD-L1 expression levels, similar to what we did with pembrolizumab, but at the higher levels this time, since we were only including patients with PD-L1 greater than 50% in this analysis. And as you can see on the left side, the higher the PD-L1, which is connoted by the pink lines there, those are the patients that did the best with PD-L1 expression greater than 90%. The darker lines at the bottom are the patients who had chemotherapy despite their PD-L1 levels. And we see a similar story with the progression-free survival, higher PD-L1 connoting higher, better response to the therapy. This is PD-L1 expression level, a little bit more granularly looked at. So it's the same thing that we were just looking at, but this is the median response or regression in tumor size based on the PD-L1 expression. So a smaller or better response to greater than 90% PD-L1 down at the bottom. So we have the monotherapies, and we're using those for our patients, but we all know that some of those patients aren't going to respond even if PD-L1 is 100%. And so what to do with those? Maybe your patient still is not a good candidate for chemotherapy. We have IO combination therapy for those patients. So Checkmate 227 looked at nivolumab plus ipilimumab, a chemotherapy-free combination that we can use in patients. And this one's out past a 4-year update now. The most recent update was 4 years, and we have overall survival that's maintained into the 4th year. So these patients were randomized 1-to-1. We look at the part 1A, Nivo-Ipi versus chemo versus Nivo, and they were randomized and stratified based on their histology, squamous versus none. They were all included. They had to have good performance status, as you would expect. This is very little, I know. At the top, what you see is the overall survival for the patients at 4 years, including all of the patients versus squamous and non-squamous. There was a 29% overall survival at 4 years, and it's maintained despite histology. Here we have the, that's so small, I can't even see it myself. Let me just turn around, because I put my glasses on, which I never wear, but I can't even see that, so I'm sorry about that. So here we have the PD-L1 expression level. I didn't do that. There we go. PD-L1 greater than 1% in the top right, or your top left. Those patients had an overall survival of 32%. These are the non-squamous patients. Down at the bottom, you have the squamous patients with PD-L1 expression greater than 1% with a 20% overall survival. So we know that the squamous patients don't do as well, but still doing better than chemotherapy, where it's 6% with the squamous patients. On this side, we have the PD-L1 negative patients, non-squamous, 25% overall survival at 4 years. That's 1 in 4 of those patients. And then for the PD-L1 negative squamous patients, 22% compared to 5% with chemotherapy. I can turn back around now. Sorry about that. So it looked really good on my computer, I promise. It looked great on my computer, so I was all excited. So overall survival based on treatment-related adverse events. So what do we do for patients when we have to take them off therapy? You should encourage your patients that they can still have a good outcome, because patients are going to be, innately concerned when they find out that they can't do any more of their treatment. Your LFTs are 4 times the upper limit of normal. We can't give you any more. You've had pneumonitis, you had colitis, and now you're on infliximab. We can't give you any more immune checkpoint inhibitor. So, well, what should we tell them? For the patients who had their therapy discontinued because of adverse events, 44% versus 29% overall survival at actually 4 years. So they actually still have really good outcomes even when they can't continue therapy. And that's one way that you may be able to encourage your patients when they find themselves in that situation. Because of symptoms, burden of disease at the time of presentation, again, we saw screening is not quite great yet, and a lot of these patients present with symptoms and stage 4 disease. Sometimes it's inappropriate to give them a chemo-free regimen, and we have to explain that to patients, even the ones who don't want chemotherapy. In that case, chemotherapy plus an immune checkpoint inhibitor is the standard of care, as long as those patients don't have actionable alterations. And Keynote 189 is probably the most popular regimen that we're using right now for these patients who have PD-L1 from 1 to 49 or PD-L1 negative. Those patients were evaluated in this study if they had untreated stage 4 disease, no actionable alterations, a good performance status, and controlled brain disease. They were stratified by their PD-L1 expression, whether greater than or equal to 1, and then they were treated with platinum therapy, and they were stratified based on that platinum, carboplatin versus cisplatin, and their smoking history, smoking versus none. So they got pembrolizumab, 200 milligrams every 3 weeks with pemetrexed and carboplatin. There is a Keynote 407 comparator or kind of sister trial to this that I won't go into just for the interest of time. But those patients were then treated with maintenance pembrolizumab and pemetrexed. In the placebo arm, they could be treated with maintenance pemetrexed if they had non-squamous histology. And then they were treated until progression of disease or loss of clinical benefit. Here we look at the PD-L1 expression levels and the overall survival. So at the top left, you see all comers, and so again, I can't see that, so turn it back around. This is how you teach a lecture, right? So anyway, the intention to treat population, 45% overall survival at 2 years. For the patients who had PD-L1 greater than 50%, which is down here in panel B, that's 52%. So like we've seen and heard in all the other diseases, PD-L1 level can show you patients who are going to respond, but we know it's not the only way to look at that. PD-L1 1 to 49, 44%, and then PD-L1 less than 1, still a clinically significant benefit with a 49% reduction in death, 39% versus 14%. The subgroup analysis looks really good for all the patients that favor pembrolizumab versus pembrolizumab plus chemotherapy versus chemotherapy. And this one, like the 9LA, the nivolumab ipilimumab trial, also includes brain metastases. So we have data from 227, we have data from 189 that all show benefit for patients who had brain metastasis. And as we just talked about, 9LA, so we have 189 and then we have 9LA, which is a chemotherapy plus immune checkpoint combination, nivolumab and ipilimumab with only 2 cycles. In the 189, we have 4 cycles of chemotherapy, so in 227, only 2 cycles of chemotherapy plus nivolumab and ipilimumab. And very similar design, except the nivolumab here is flat dose. It's 360 milligrams every 3 weeks plus ipilimumab 1 milligram per kilogram every 6 weeks. With chemo versus chemo, the patients were randomized 1-to-1 to these 2 arms and treated until disease progression, toxicity, or up to 2 years. And we'll turn it back around. All right. And so we look at the overall survival for those patients. Overall, at 2 years is where the follow-up with this one is 38 versus 26% overall survival, which is great. But then when we look at the patients who had no PD-L1 expression, which is down here in B, still 37% of them alive at 2 years, so not really much difference. And that's the reason why this and 189 are indicated regardless of PD-L1 expression. Nivolumab plus ipi with chemo over here in A, this is for patients who had PD-L1 of at least 1%, 41% at 2 years versus 28%. And then at 50%, 45 versus 32%. So just like we saw with the other trials, the higher the PD-L1 expression level, the more likely the patients are to respond. Subgroup analysis, again, favoring those patients with the nivolumab plus ipi plus chemo, except where we see patients who are never smokers, similar to what we saw in the previous trial, and then a little bit elderly patients. But there are probably some other comorbidities that were contributing to that. And again, a smaller number of those patients. This looks at PFS2, so patients who were able to go on the second-line therapy after progressing on the nivolumab plus ipi plus chemo, and we can see that the PFS2 at 2 years was 35 versus 21%. So conclusions, really the data from these 2 trials is out there. We know it, it's very important, but I think that screening is really where we need to focus our efforts. And I appreciated Dr. Ritchie's talk, but I was not going to take this part out on screening because I think that we are doing a really good job for these patients with stage 4 disease, but this is not a home run. I mean, it's not a slam dunk. Still, we have less than 30 or 40% of those patients alive after 5 years or 4 years, depending on which trial you're looking at. And that's just not quite good enough. We want to do better for the patients. We want to diagnose them earlier. So really, who should be screened is everybody with lungs should be screened. If you have lungs, you should get a lung screening, just like everybody with breast gets a mammogram. If you have a colonoscopy, it's if you have a colon, a colonoscopy is recommended. So, it's crazy to think about giving me a CT of my chest every year because I don't smoke. But once every 10 years, it's not unreasonable. So a risk stratified approach to lung cancer screening is what we need. We do that for patients who are high risk. We say, okay, we're gonna screen you again or look at you again at 6 months or at a year because you had a nodule or an inflammatory infiltrate that I'm concerned about. I don't wanna wait, this amount of time. But for patients who aren't smokers, we should screen at least once every year starting at 40, 50, 60, 70. And then if you have a nodule, maybe we bring you back sooner. If you were ever a smoker, maybe we bring you back in 5 years, just like if you had a polyp, you don't come back in 10 years. So really, until we change the way we're trying to do screening and then make it available to everybody, because at least 15% of our patients who have lung cancer were never smokers. And that's almost 1 in 5. And if you take us 1 in 5, who wants to be that one? Nobody. So I want a CT. I actually already had one, not for that reason, but it's because I had COVID. And so that's another way that we've been diagnosing lung cancer. Even though screenings went down, patients have been coming in with symptoms of COVID and actually getting some scans that have brought them into our clinics with new diagnosis of lung cancer that would have otherwise been undetected. So the conclusions, beyond the screening, improved survival for patients. We can use monotherapy when it's appropriate. That has to be a specific patient population, high PD-L1 with low tumor burdens that we may be using a monotherapy in. But then there's a combination IO with 4 years of follow-up that shows benefit, and then chemotherapy plus IO, whether pembro plus chemo or nivolumab plus ipilimumab and chemo. Also, cemiplimab, which is the one that's there in the middle, approved in the first line for PD-L1 high patients. There's an Empower Lung 3 trial that's coming that will show us the addition of chemotherapy to cemiplimab. So we're having more and more of these regimens available. TIGIT, LAG-3, and some of the other immune checkpoint pathways. There's also still work with the CAR-T in solid tumors, but that's moving about as fast as those immune cells through those tumors. So it's not going that fast, but there is still work on that, and hopefully we'll see some benefit from all of those therapies. That's it.